welcome to CDA Oasis. My name is Shiraz Gesayer. I am pleased to welcome to the first case presentation of 2020, Dr. Paul Belzycki. Dr. Belzycki is one of our frequent presenters on Oasis, and he is here to present the fourth case in the implant series we started last year. Dr. Belzycki is a dental surgeon from Toronto who has practiced dentistry for 4 decades, and he kindly shares his invaluable clinical experience with his Canadian dentist colleagues. So Dr. Belzycki, always a pleasure to host you on Oasis. Thank you for your time and effort with us.
Hi, and welcome back, everybody. Happy New Year.
So like we do all the time in these case presentations, my first question to you would be, what is this fourth episode about and why is it important?
Trying to lend some structure to these presentations. As I said before, I can't take people by the hand and show them step by step by step. So each one, I've tried to focus on something different. One was the importance of treatment planning. Another one was on the geometry of the restorations that we put in the mouth and how we plan for that and communicate with that and why it's vitally important. And this one, as it pans out, is just on the concept of margins. I think the benchmark of a good dentist is how well you manage margins, both on teeth and on implants. They're both vitally important. And I can't focus on everything at once. I thought I would just focus on margins and how I've handled it personally. These are all my experiences.
So I'd like to let our viewers know about two things. The first one is I had the pleasure to meet your patient whom we are talking about and presenting the case. And we will have that also for our viewers as a separate conversation. And the second one, I believe he was in your office because you were checking on him and we have updated pictures of the case, correct?
Yes, when we were filming this, he just happened to be in that day. And I didn't look at the day sheet. I thought it was fortuitous. And I thought maybe it would be neat because we always show cases of disembodied teeth, just teeth. And we have to remember that these teeth are attached to individuals and is just not treating teeth. It's treating individuals as well. I just thought it would be neat.
Oh yeah, it was, and the conversation was great. Actually, I'd invite our viewers to see it. Thank you for that. This is the first time we do it. We always look at teeth and not the person, and it was nice to talk to speak with the patient. So, shall we go and see the presentation?
Yes, we shall. Welcome back, everybody. It's a new year, new decade, 2020, and we're sharing my implant experience. For those that are new to the presentation series, let me tell you I'm a general practitioner. I provide periodontal surgery, endodontics, restorative dentistry, both simple and complex. I have a whole range of patients that I've been caring for now 4 decades. I don't particularly place implants. I tried doing it, was never comfortable. I'd rather leave that to a specialist with extra training. But I endeavor to integrate all the protocols in dentistry to deliver long-lasting restorations in terms of decades, because that's what I would want if I'm sitting in a chair, and I'm sure that's what you would want. Fix it once, but fix it as best as you can. Give me your A game. And that's what I try to do for each and every patient. So after 40 years, I've restored just about everything there is to restore in dentistry. And hence, I'm well versed in what does and what does not work. And of course, I'm doing it old school. So to define that, I rely on evidence-based protocols that have proven successful, not only in my hands, but in the hands of those that wrote textbooks, that teach at universities. They made up the rules of the game. And I'm inclined to follow those and not reinvent the wheel. There is no Belzycki technique. What may be unique is just the fact that I do most of the protocols of dentistry here. It's one set of hands doing it. And I just feel I can bring a common vision to the work that I provide. And as always, success is a planned event. You don't bump into it at the end and say, oh, look, this is a good one. You have to struggle for each and every detail. And you have to get each and every little step right. So I'd like to focus on margins because it's a very key component to the success of our restorations, to make sure that they last a long time. So we instinctively know, you don't need any discourse from me, you instinctively know this isn't right, this isn't the way it should be. This is what we would like to strive for, particularly on teeth. And whether it was done in 86, 95, or 2004, they all have a common appearance, because what's correct hasn't changed. You still need restorative material. These happen to be porcelain fused to metal, which is my favorite, because as proof of this photograph, they just keep on lasting. So you have to have good restorative materials that are durable, and you have to prepare teeth properly, capture them in an accurate impression, and have a lab that's dedicated to being precise. There's nothing new in these statements. The margin forms a critical seal to block the ingress of bacteria and oral fluids. So it has to be as good as you can make it, recognizing there's no such thing as perfect, but you still strive for perfection. There's inherent inaccuracies in everything we do. We try to keep those under control and make the errors as small as possible. Two components are required for a good margin management. As I said, one is the fit and finish of the restorative material, and in conjunction with how well we prepare that tooth margin and capture that impression. But an equally important concept is margin location relative to a healthy periodontium. Whether it's on a tooth or it's on an implant, you can get your perfect impression. You can carve the tooth properly, but if the margin's in the wrong place, you're going to have problems. So as it happened, this came in last day. This patient, I put these crowns in 2000, and she snapped off the lateral. I wanted to make a 2-unit splint after I put a cast post core in this tooth. So I cut the crown off of this tooth. Now this tooth has been in service in the patient's mouth for 20 years. And this cement, my favorite, polycarboxylate cement, poly-F, that's the way it looked. The second I cut it off of the tooth, I thought I'd snap a picture. So I would tell my patients, they would ask me, how long will this crown last? And I would say, look, it's on for life. That's what I'm trying for. A little bit of porcelain could break, something could happen. If that does occur, it's just a matter of cutting the crown off and just exchanging hardware. And this is proof of that statement. This is the tooth. I have not touched this tooth since I cut the crown off. I've been working on this tooth, doing the endo and getting it ready for a cast post core. So this tooth, it looks like the day I cemented it in. And the cement looks like the day I cemented it in. And that's just no brilliance, just dedication to detail, making sure that my margins are just tucked underneath the skin and having a good lab that can make something worth putting into somebody's mouth. So with that, let's just delve into this rather lengthy case. I'm sorry if the presentation's kind of long, but there's a lot of meat in this case. So this is an otherwise healthy a healthy 60-year-old male. He's been with me since about 1995, and over the years he's required a lot of treatment. And some of it is a result of living in a jurisdiction that didn't have fluoride. So all of you anti-fluoride people out there that may be watching, this is what you're going to end up with, which in some regards is good for dentistry because we get to make more money doing more dentistry. Some of it is a result of a chemical dissolution. He had poor oral hygiene. And I asked the patient when doing this presentation, I'm going to say that, and your face is attached to that. Do I have permission? And he gave me permission. He said, Paul, just tell it like it is. And I'm trying to. And then He was doing something that I label as something with a question mark. I used to ask him constantly every time he came in, like, what are you doing? Are you sucking on lemon rinds? Are you taking vitamin C lozenges that are chewable and increasing the acidity? Is it wine? Is it Fisherman's Friend? Is it Halls? Because some people think Halls is actually a medicine when it's just a sugar candy. And either I wasn't smart enough to ask him what it was that he was doing, or he just didn't want to tell me. We had gone over gastric reflux and things of that sort, but we could never pin it down. But he was doing something, and I've never been able to define that something, because it's a lot of dentistry. And to get dissolution of enamel off of the facial surface, you have to be doing something. You have to be working at it. Could never figure it out. So these are amalgam restorations, thankfully, that have withstood the test of time, and so have these full gold crowns. And I did these PFM crowns somewhere in the late 90s. He came in 2007. I was out of the city. He had a flare-up of a tooth, and he had endodontics done with a specialist, and he presented with this broken tooth and needs to be fixed. So I said, fine. I can see here that there's a large composite resin filling. The distal incisal corner is broken off, and I thought, wonderful. We'll put 2 crowns on these 2 teeth, and I'll splint them together. I love splinting teeth together, particularly if they're endodontically treated, because that way I can, in my mind, guard against future root fracture. And here you can see the radiograph, the extent of composite resin that was in the lateral. Prepared both teeth. When I prepare a margin, I try to follow the soft tissue outline. Come coronal when I have to, apical when I have to, and just not go around 360. You have to follow the undulations of the gingival contour. So here are the 2 crowns, porcelain fused to metal, a metal island on the lingual, and that helps reduce at least some of the attrition if he's occluding with the lower teeth. And the 2 crowns were put in 2007. In 2008, he returned, and just to show you, just in his mouth, there was always an exaggerated response to decay and inflammation. And just his physiology, just to outline some of the problems I had in just managing soft tissue. And some years later, in 2011, Paul, I've got a problem. I've got pain from tooth 13. Took a radiograph, and there's a lot of decay. So that I knew was existing, but I looked at the facial surface here, and I thought, that looks to be a problem too, because on the radiograph, I could see there's a certain radiolucent density to the canal in this area, but in this area, the canal is more pronounced. So I knew there was a loss of hard tooth structure, making the canal look that way. So the first thing I have to address is this tooth restorable? So I come back to margin placement. So from experience, I've learned that there's rule 1. And rule 1 is you can't fool Mother Nature. No matter how you practice, no matter what techniques you use, you can't fool Mother Nature. And by that I mean, you must not violate the biologic width, which is the body's delicate barrier between the body inside, the connective tissue, and the world outside, which is the organisms and the oral fluids. Very, very harsh environment. So when we place crown margins or any restorative material, and we're approaching the gingival sulcus, and that biologic width is only 2.5 millimeters on average. So this is the tooth, this yellow is the enamel, there's a potential space or gingival sulcus. We have an epithelial attachment, connective tissue attachment with collagen fibers into cementum and bone. So when we engage this area, at best, ideally, this is what we would like to do. We would just like to tuck this into the sulcus. But in a real world, we're often chasing decay that goes beyond that. So we push it sometimes, get a margin, a crown margin or a restorative margin a little bit deeper. And we hope that we can capture that margin with good fidelity and then have a lab that can give us a precisely fitting restoration. But sometimes it comes back. It's a little bit bulky, sticking into the skin. This is just another insult the tissue has to accommodate to. And of course, the deeper you go, the harder it is to get an accurate impression. And then there's this, just taking a restorative material and just slamming it into the soft tissue. And that was the radiograph that I showed initially on a margin that just doesn't look right instinctively. And this is what we don't want to do. So first things first, before I invest time in endo and buildups, et cetera, I have to answer the question, is this tooth restorable from a periodontal point of view? I had great crown length, so I knew if I had to, I could do crown lengthening. So what I did first was raise a flap, and I identified and removed the decay. Sometimes the decay is so deep, it just undermines the entire structure, and you know the tooth is not restorable, time to pull it out. I can't discern that from a radiograph. I've got to see it, I've got to feel it. So I raised the flap, took the decay away, and I could see that I got into the canal in this area, entered into the canal space here, and then there was a bridge of dentin, a good bridge of dentin covering that part of the canal. So there was some decent tooth structure to work with. Recognizing that I would keep the tooth and I could do the endo, which I would all do on one appointment, I just placed some soft, either die-cal here, or I may have placed temp bond in this area just to cover that canal so I could get into it immediately after restoring this tooth. So at this point, I could see it looks as if I have some good surface area for a soft tissue attachment. I'll just take that away. You need about 1.5 millimeters to 2 millimeters. And I thought that looks reasonable. I've tried to highlight it there. And then using 2 assistants, trying to control moisture. I placed the composite resin restoration here. I really didn't care too much about the seal of this at this point. I just needed some barrier so I could do my endo, close the flap, and send them home. And I would worry about a better restoration at a later date. The decay was removed from the mesial aspect. And here you can see the progression from wondering, could I keep this tooth, removing the decay, covering the canal, and getting some sort of restoration, and then going on to do the endo. So now with that restoration, I could place a clamp on this tooth relatively atraumatically, and then do the endo conventionally from the lingual. And that's how it was done. Able to control moisture in this case, in this instance, and then place the composite resin filling. Because this was a 2 or 3 hour appointment, it was quite enough. And remove the rubber dam, put in my sutures, sent them home. Comes back within a week or so to take the sutures out, and this is typically how healing will look. And for the endodontists out there, there's my endo. Later on that year, in December, he came in and he said, something doesn't feel right. In the upper left quadrant, he had some puffiness around the gingiva and smelled bad when he flossed it. And I could see I've got decay that started off all over again. Tooth 24 under a crown that's been in for some years. So that tooth was extracted a month later. He came in 2 years later saying, I've broken these 2 teeth, and now it's time to restore this area. That was the original composite resin I had put in at the time of surgery. I tell people, look, you had an endo done. Come back, let's get a crown on as quickly as we can. And some folks say yes, and some folks say, it's not bothering me. It looks good. I'll call you when I need you. And that's fine by me too. I don't mind letting symptoms dictate treatment. I don't sell dentistry. You wait long enough, dentistry will sell itself. So I prepared these teeth. After I got rid of all the weak tooth structure, this is what I was left with. I wanted to take an impression for a cast post-core. Used a little bit of electrosurgery to remove some redundant tissue, overgrown tissue. Put in my little plastic end dowel, painted with adhesive so that VPS impression material will stick to it. So if you are just basically doing a digital impression techniques, you can't do this. I do still VPS impression of material in a custom tray, so I'm able to capture the length of the canal, and a cast post-core is made. I'm very comfortable with these. I've used them for decades. They don't break. They just lock down a tooth, and if designed properly with taking into account a skirt to engage ferrule in the implant, they go on to last quite nicely. So that was inserted, and the day of insertion, I just didn't like the way this tissue looked. And I thought, it's time to address, is there enough root structure, root surface for a good zone of attachment? Provisionals were made and inserted in the presence of a flap. And now, when I say words as I did at the beginning, the integration of perio, endo, and restorative dentistry, it's a very flowery statement, but here it is graphically represented. It's the fit and finish of the restorative material in relation to a healthy periodontal complex. That's what has to be established. So I've made provisionals fit to the best of my ability, and these are methyl methacrylate powder liquid, so I can add and subtract incrementally at will. They're cemented in. I've defined the margin, and I've tried to get this to fit as best as possible. Now I can come around here and say, well, I've got to take a little bit more bone away. And you can do this with a little scalpel blade, a number 15. You lean it up against the bone, and it just cleaves off. And you can take off little by little. Now, doing it old school. If a laser can't help me here, then I see no reason for a laser. That's my own personal opinion. And this series of presentations is how I practice in my personal opinion. So a little bit of knowledge and a very inexpensive scalpel blade, I can sculpt this bone to a high degree of accuracy. So the importance of properly contoured provisionals cannot be overstated, because the provisionals will guide the healing phase. That's very important to understand. It's the interrelationship of an artificial material with a surgical phase. So this can't be 1, 2, 3, let's get it in, it's the end, I've got to rush this out. No, you have to spend as much time making this as good as you can, because that will go on to guide the tissue into healing properly, or at least won't interfere with the healing of the tissue. Because if I take away enough bone and I make a beautiful margin, but my provisionals are over contoured, it will interfere with healing. I don't want to do that. So a few months later, he comes back. These are the provisionals. The tissue is beginning to look healthy and reasonable. In late 2013, 3 crowns were made, porcelain fused to metal, and they were inserted in healthy tissue. So this is how we started. 2011, when we first presented, I've got a problem, I've got decay. After a year or two, he presented, I've chipped these teeth, can we fix the area? And that's how it was carried out. And we attained a very reasonable smile in October of 2013. As I said earlier, 24 was extracted in January of 2012. And sometime in 2013, I'd taken some radiographs and I could see this area, the distal of the 23, is not healing properly. Took a radiograph and I could see a hint of a shadow here, which is indicative of some form of root resorption. So that tooth, and I said, let's pull this tooth out. He said, look, it's not bothering me. I can live with just a space in the of the first bicuspid. I don't want to deal with this right now. It's not bothering me. So I said, fine, when it bothers you, let me know. And it started to bother him in June of 2015. And that tooth was extracted. And now we've got to restore teeth because he doesn't want to live missing a cuspid and bicuspid. So started to look at restoring these teeth, and we did have decay under a crown on the 27th. So endo had to be initiated there. The existing crown was removed, and I placed an acrylic provisional. It's nice to do it this way because light will go through. It won't be blocked out as it will with the metal substructure. And of course, it aids in finding two mesiobuccal roots when you have good light and good visibility. God forbid just to have one major mesiobuccal, but he had two, and there was the palatal canal, and the endo was carried out. And now it was time to restore the area. The socket had gone on to heal a bit, so he came in. I removed my 2-unit splint that I had placed in 2007. I removed these crowns and start restoration of the area. And I could see I've got tissue here which is angry. Part of that reason is a root proximity problem between the distal buccal root of the 26 and the 27. And there you can see it. Raised a flap. And I had to do this anyways for some crown lengthening here just to address the extent of decay in these areas. And I thought, this is neat. I've run into this so many times. I know what the anatomy is. I don't need a 3D cone beam scan. I can visualize what the anatomy is just from that periapical radiograph and the fact that I've done this so many times. I just have to come in here, and the endo's been done in this tooth already, so I just have to trim that little bit, and that distal buccal root will come away cleanly. And that's what was done. And all of a sudden, I've eliminated a root proximity problem in about 10-15 minutes and made provisionals to fit that shape. So here you can see the issue. When you have the fluting between this root and the palatal root, it's impossible to clean. Even if I could resolve that tissue, with that root in place, it would always be a problem. So this way, you can drive interproximal brushes through here very, very easily. 1 week later, he came in for suture removal. This is what it looked like. There it is from the palate. And uneventfully, in the course of a few months, it goes on to heal, and the tissue plumps up quite nicely. So I have a provisional bridge made out of methyl methacrylate powder liquid, which is what I use. I don't use composite resin for my provisionals because in long, drawn-out cases where margins need to be reconfigured or where teeth need to be extracted or people aren't sure they want the tooth longer, shorter, wider, whatever, it's good to have a material that you can refine constantly. You can add and subtract at will. So we have a bridge going from the two centrals back to the 25, 26, 27. And there are our two pontics. I did another surgical procedure here because if I was addressing this area. I want a more uniform smile line. It wasn't specifically for that. The tissue just, it needed to be cleaned up. And that's the best reason I can give. So I sat with him and I said, we have to make a critical decision now. What will be the final design of the restoration? Because we have stability of these two teeth, the 21 and the 22. Somebody took me to task on a previous presentation that it didn't say tooth 2-1 and tooth 2-2. I'm sorry, I'm using it interchangeably. But we've got these two teeth, which I would like to restore again with two splinted crowns. I can restore this segment with some splinted crowns. If I make a bridge, all of these teeth have been endodontically treated. And yes, there is the risk of root fracture with endodontically treated teeth. But that really didn't worry me all that much here. What really bothered me is his past history of a sudden onset of decay. He claims that, Paul, that was then, this is now, I'm cleaning better, I'm brushing better, having gone through all this work. It just bothered me that if I strap all of this up with one porcelain fused to metal bridge, if he has a problem here, I have to sacrifice an entire quadrant to make something right. So I thought, let's secure the two front teeth, we'll secure the back three teeth with some crowns, and then we'll place two implants in this area. That way, there's not this interrelationship throughout the entire quadrant. And he thought that was a reasonable idea. But he said, look, Paul, I know about these implants. They take forever. At no time do I want to be without teeth. And I said, you won't be a day without teeth, because with methyl methacrylate provisionalization, it's easy to add and subtract as required. So that's why I use that material. The lateral 22, 2-2, required endo. There was just a lot of composite resin. I didn't know, I just wanted to lock this tooth down. I do not do endo preemptively. There's no, well, we're putting a crown, we better do it because you might have a problem in the future. I don't practice that way. But in this case, I thought it would be a good idea to get the endo out of the way, given the complex of composite resin material that was there on that tooth. So again, another cast post-core was made, and that was inserted. Again, I'm sitting here at my desk, pontificating. Why should anybody listen to me? Well, your methods and materials. Here is this tooth in 2007, and some 8 or 9 years later. It looks every bit as nice as the day I put it in. That little nick was just the result of trying to slice the crown off and not do too much damage to the composite core. I very rarely use a composite core buildup on anterior teeth, but for whatever reasons, I did place a dentatus post in this tooth back in 2007 with two little TMS pins to secure that. I didn't rely on bonding. This is not a bonded composite resin core buildup. This is locked down by mechanical retention. I don't rely on bonding. And it was at that point I could measure the distance between these two. Between this tooth and this tooth, it was some 14 millimeters, split the difference, 7 on each side, and that's where the implants would go. This information, these photographs were taken. They were sent to the oral surgeon, who in this case was Dr. Jeff Farber, wonderful, wonderful surgeon that I work with quite a bit. And let's make the surgical guide on the prepared teeth. I'll be there at the appointment, which is my habit. We'll take off the provisionals and we'll place a guide on prepared teeth so the gentleman is never without teeth. And this was the guide that was made with his input using his diagnostic material. Time of surgery, these are the photographs I've taken. As I said, I attend all of these surgeries, and nothing more sophisticated than two little pencil lines, kind of guides where the implants go. And as I've said before, I love these sorts of pictures. I want to know what those implants look like the second they're put into place. So I can have this knowledge, this diagnostic radiograph, this diagnostic photograph later on. Should there be a problem, we don't scratch our heads and say, geez, what did that look like the day it was inserted? Now I know what it looked like the day it was put in, and if there's a problem later on, it's good continuity of care. Because I was there, Jeff could go on to the next case he had, and I would sit there and I took the provisional bridge, recontoured the pontics, the underbelly of the pontics, so it would go to place. I cemented the bridge in. And he returned back to my office a few weeks later, pulled off the provisionals, and you can see there's just the remnants of the sutures that were put in. The healing caps were closed underneath the tissue. This would require a second stage. And I had 2 provisionals as a just in case, should something break, come loose, I don't know. I just had 2 made up. 6 months later, his second stage surgery. Again, I could cut the underbelly away. These are the original provisionals he's had in for some months. Just knock those off and reconfigure them to accommodate the transcutaneous or transmucosal abutment. Took an impression. I thought it would be a good idea to make get started on the metal frameworks on the teeth first. So I got an impression of the teeth, and I had the copings come back in separate units. And this is how I do all my cases. If I've got splinted crowns, even if they're 2, I still have everything come back as separate units, because I need to try in the metal to satisfy my little pressure transducers in my 2 fingers. I want to put these into place, and I want to discern, is there an impediment to that retainer going to place smoothly? Is there a jiggle? Is there a wiggle? Is there a rock? I want to know, because we can make errors. We're human. Whether it's a lab technician working with wax or it's somebody fiddling with a computer, there are inherent errors in every system. So the final arbiter of what is correct is in the patient's mouth. So the provisionals are pulled off, and you can see here the tissue, what it looked like earlier on compared to what it looks like now. This is textbook. There's no bleeding, there's no sulcus moisture. Now it's a pleasure to do work. Now I can insert all of these copings individually, assess them for their accuracy of fit. If I feel I need more embrasure space, I can grind that in now. Because a lab doesn't know the soft tissue. They don't know what I've put this patient through to get him to this stage. They don't have a clue. When you do periodontal surgery, you become far more respectful of the soft tissue and soft tissue management, because you've seen the hurt that you put that patient through. So you want to back it up with good restorations. And now I will take some tooth-colored resin material. It could be the red Duralay. I've got both, but I seem to use just whatever I made the temporaries with, I just use because I have so much of it. And I do this intraoral solder indexing. And what I'm trying to do here is accurately relate each individual coping to one another as they sit on the teeth. Because it's different on how it's going to sit on a master model. That stone, it can have certain built-in inaccuracies, but I know, and this is how I've always done it, I want to relate each coping to each other as it sits on the tooth. And when I know that there's no rock and everything goes to place as one, I lock that relationship in. Then I make the all-important solder jig. This is a verification jig. Sometimes it will go to place. This is just a second pour of the VPS impression that was given to the lab. This is just a second pour, and these are pinned dies. And sometimes it fits nicely, and sometimes it won't, because it may be different a little bit. How it fits on a model as to how it fits on a tooth. Now I've locked in how it fits on the teeth. So I take each individual die out and just insert it into its respective coping and attach it with a little bit of sticky wax and plop that into some stone. Now, in transport, if somebody drops the case, and the lab always, a lab technician dentist will tell me, sometimes a driver in a hurry, the box falls out of the car, models are going everywhere, things get broken, it happens. So if that intraoral index comes apart, they can put it back together, because this mimics how those teeth sat intraorally. So a verification jig accurately relates the dies to each other as dictated by how the metal copings fit on the teeth intraorally. So whatever they do there after their soldering and porcelain processing, if it doesn't fit this accurately, it won't fit the teeth. Before I did the solder indexing to this tooth, to these two copings, because I have everything back in bare metal, I can assess it for its contour as well. And I can see that's not leaving me a lot of room for porcelain to match this incisal edge. It happens. But I can assess that's too long. Without the porcelain in place, I can measure that coping. I see that it's 2 millimeters in length. So it's easy to reduce the thickness of metal. At this appointment, when I do the metal try-in, I will now take the impression for the two implants. So here you can see the solder indexed metal copings, the two implant transfer copings that are in place, the impression copings. I always use an open tray technique. So these are the index copings, and they're placed on the teeth, and they're secured with a little bit of light body VPS impression material. I take the custom tray, cut a hole where I think the implants will exit out of, or the implant copings, squash it onto the arch, and I see that's the head of the cylinders. And then I will cut that little space out, take my impression. Now I can access these two quite easily. So methyl methacrylate custom tray, it can be used creatively. The impression's retrieved. Now I just pull a little bit of impression material out of the metal copings, attach the two implant analogs, that goes off to the lab. So now they have an impression for the implants relative to the metal of the bridge work that will go on teeth. And now I can guide the lab. And these pictures just go back and forth. So I Photoshop this, I take a picture, I send it to the lab. Don't flare out into proximally. When you come with your contour, that tulip shape of the emergence profile, I don't want it flared into proximally. I don't want to choke off this tissue. If you want, you can flare it this way a little bit, that way, and a bit buckle, just to bulk out this tissue, but don't overdo it. And make the crown margins just under the gum line. And we kind of knew that this would have to go with custom abutments, because the screw holes would just come out the buckle aspect of the crowns. So these are custom made abutments. Make the metal copings at the lab. I don't want to take impressions by putting an abutment on an implant and then trying to pack retraction cord around that, because how tissue accepts retraction cord around a tooth is not the same around an implant. You're going to damage the tissue around an implant, and you'll bury the retraction cord and not get a good impression. So here we are trying in those two abutments, custom abutments. Again, note months of wearing a properly contoured provisional. The tissue is pink and healthy. All the metal is inserted. Here, it's been soldered. Check it for fit, and they fit quite nicely. Now I'm going to solder index these two as they sit on the abutments, as the abutments sit on the implants in the patient's mouth. Then I know I have the best accurate representation I can manage. And I've asked the lab, the margin, the crown margin that this is supposed to fit on, I just want it no more than 1 millimeter under the gum line. If I show a little bit of metal here in this area, in this particular patient, not hypercritical. I'd like to hide it if I can, but it's not the driving issue. Oh, I have to make it cosmetic and bury it. I'm not worried about that in this area. So that margin for this metal coping is just tucked under the tissue. So on my crown, that will be cemented in. And of course, I would love to go with just screw retain for retrievability, but sometimes you're forced to use cemented crowns. So I want a fine metal margin against the metal of the coping, of the abutment rather. So the concept is to keep cemented margins accessible to aid in removal of cement. The literature is replete with articles on the failure of implants, not because of the surgical aspect, not because of necessarily bad fitting crowns, but cement that was too far under the tissue that couldn't be retrieved. So I want that margin accessible, as easily accessible as possible. And this is the configuration. Those are the analogs. That is the custom abutment, and those are the crowns that fit on there. And the concept is to present a smooth, uninterrupted surface for that fine, delicate little attachment that we're going to get the tissue against the implant. So I want it smooth, uninterrupted, keep crown margins as close to the gum line as possible for that very delicate hemidesmosomal attachment of the surrounding epithelium. So you need every bit, the attention and detail I gave to margins on teeth is the attention to detail I have to give to margins on implants. It's the same, yet different. It's a different animal, but there's protocols that are accepted, that are written about, and you have to follow those. You can't make this up as you go along. Solder index and evaluation of the metal design. With no porcelain in place, I can see what was their concept at the lab. Did it match mine? And I could see that they had not yet reduced enough metal in this area, nor in this area. So it's very easy for me to come along, grind a little bit away, snap a picture, and send them the lab this note. I've adjusted the metal over the incisal edges. You will need to adjust metal elsewhere to make room for porcelain. Do not remove the metal islands here, that little stop. Narrow them if you want, but I want to see metal. The metal stop here on the molar is slightly short in the mouth. So I knew there wasn't enough metal there. I've remounted the case. The mounting is correct. I love doing lab work at my office because I know that if I've done it, there's a good chance it'll be correct. So they know, start trimming some metal away to make room for the porcelain so we get the length of teeth that I want. And the case is completed. The pretty porcelain, which is the easiest thing to do, As I've often said, the pretty porcelain, yeah, it's there. For all you cosmetic guys, here you go, pretty porcelain. But what has to be aesthetically correct for me is the underlying structure that supports the pretty porcelain. The day of insertion. The case, there are no surprises because I've worked out all the surprises. I had plenty of surprises, but I worked them out before the last day. So I've got healthy tissue. Insert the abutments on the teeth and make sure take a check radiograph because you can be fooled. You can get hung up. These were the old Noble BioCare Select. I'm sad that they took them off the market. I really like these implants. And the case can be inserted with no surprises. I knew before I got the case back it would be okay. And here are the radiographs. Treatment can be carried out with confidence. I've worked out all the problems. So this is a year or so after I did go ahead and restore some of these bicuspids at a later date. So porcelain fused to metal. The ability to integrate all various phases of dentistry is indispensable in planning and executing treatment that is comprehensive in scope. And comprehensive just means there's a lot of little problems. It's a congery of multiple problems, small ones, and each one has a simple solution. You just have to find the problem, identify it, and manage it. So you have to envision all the steps required to achieve an optimal outcome, even though you're not comfortable executing some of these steps. So if you're not comfortable doing perio, I understand. Work with somebody that you can share a vision with, that you can say, this is what I'm working towards. What do I need to do? How can you help me? And have good communication. That's very key. So collaborate with specialists that are willing to develop and share a vision of an optimal outcome, because not everybody is. And finally, who's the quarterback? I've mentioned that before. Who controls this all? And in my mind, it's me. It's the restorative dentist. If something goes wrong, I can't blame anybody. I can't say, oh, the lab didn't do it, or the surgeon put it in the wrong angle. I'm responsible that he gets it in a spot that I can restore it. That's why I work closely with them and try to attend all the surgeries. So there is the need to control every aspect of treatment, including guiding the lab. And as I've said, dentistry, in my opinion, my very biased opinion, in the age of digital, is still craft of the hand. Yes, a computer may make it, but it still ends up in your hand until an Uber driver gets to insert these things. A dentist still has to use his hands to insert these cases. And the long-term success is the interface between expertly crafted restorations, particularly at the margin, in relation to a healthy periodontium. And this is the poster child for that. I've said this image is burned into my memory. Every time I approach tissue and I'm entering into the sulcus, if I don't have this arrangement, if the decay is too deep, I have to create it. And that's what the need for periodontal surgery is for. Again, long-term success interface between expertly crafted restorations and a healthy periodontium, whether it's on teeth or on implants. It's the same thing. You have to have an overriding respect for that little barrier between the inside world and the outside world. And that's following established rules of the game. Doing it old school. Now, I just want to add this little thing here because I know some folks may be thinking, oh, in the age of digital, you can all, why doesn't he go digital? Digital impression taking, etc. I have no problem with that. I just have learned all the problems involved in doing it how I've been doing it. And I know that doing it a different way I'll just have to learn the new problems. I'll have to bump into them all over again. I'm getting too old to relearn. So as justification, I did this case back in 1983. This is a metal framework that wraps around. We used to call these roundhouses. It's a roundhouse because it goes right around. Before we had protocols for using implants in the maxilla for isolated areas, we would restore these cases in roundhouses. Patient came with a partial, didn't want to live with a partial anymore. So this framework was done. This is 83, before computer digital cameras and all the rest of it. This is off of Ektachrome slides. This is a case where I got everything back in sections, working with an expert craftsman, Gabriel Pintos, who I've mentioned before, no longer working, retired. Just a superlative technician. Metal framework that I got in sections, jigged up, etc., etc. I put this case in 1983. That's the picture. This is 2008, some 25 years later. And here it is in 2016. I haven't seen her for a year or so because sadly she's in late 80s and dementia's taken hold. Hope she's still brushing, but that's lasted 36 years. So if I'm going to use a new technology, that new technology has to give me this. And that's why I'm still doing it old school, because restorations start to fail immediately after insertion. And my task is to make them fail as slowly as possible so that there's the hope the patient fails before the bridge work does. This bridge has been in place for near 40 years. And it's underpinned by those 5 teeth. And making it last, and hopefully a lifetime, takes a lot of skill, effort, and integrity to nail those margins down. That delicate interface I was telling you about between the artificial material and the tooth, and the placement of that margin in that it is harmonious with the soft tissue so that the patient doesn't have problems with this during the course of a lifetime. So the fit and finish takes a lot of work. Now, my father was a tailor. Came to Canada in 48, master tailor, had a little shop in the basement. And I would often see him working up made-to-measure suits. That's what he did. And he always had people come in, he'd measure them twice, he'd make the pattern, he'd cut the fabric, we did everything in-house. And he would never go to completion on a made-to-measure suit. He would have the he would have the client come back, try the suit in with large stitching so that if a sleeve wasn't right or the pants were a little bit off, you didn't have to tear the whole thing apart and start all over again. You could just take out some of these pins and stitching and rework it so that it was just perfect. And that's how I see my task in dentistry, because there's nothing more than sophisticated tailoring, trying to get it to fit just right so you have a happy patient for a lifetime. So yes, in that, I still think dentistry is very much a craft of the hand. And it's the artistry and integrity that you bring to the task. I know this has been a lengthy presentation. And I think there's a lot of meat in here. And I hope that it guides you or helps you with some of the cases that you bump into later on. Thank you very much.